regions where there is a lot of problem.
Yes, sir. Right.
Okay. I think we'll wait for 5 minutes because let us see whether more students can join or not.
Okay, no issue.
At the moment, we have only 4 or 5 students.
Should I record the session, sir?
No need. No need.
Okay.
Okay, you can record it. I think that should be all right. You record it.
Okay. Okay, let me record.
Okay. Okay, shall we start then? Okay. Good evening, students. Can you hear me, or can you? Am I visible to you, students? Am I visible to you? Can I?
Yes,
Can you all hear me?
Yes, sir.
Okay. So today we'll have a case discussion. We need a volunteer. Any third year DM DNB students willing to discuss the case? And you should come forward to discuss cases, because by discussing cases, you gain a lot of confidence in the examination. Then you can answer questions more confidently. And also, your thinking process will be much better. You can face the examination with a lot of courage. So I think this is a good opportunity for you to come forward and volunteer to discuss the case, and then learn out of the discussions. Anybody who would like to take up the challenge? Shanmugam, would you like to do it? Are you a third year student? Anybody else who would like to discuss the case? Said, would you like to discuss the case?
Yes, sir.
Are you a third year student?
Yes, sir.
Okay, then I think you can discuss the case. We'll start the discussion.
Okay, sir.
Which institution are you attached to?
Sir, I'm in Trichy Government Medical College.
Which one?
Trichy Government Medical College.
Trichy Government Medical College. Oh, then you should be very good. Third year. So you are doing third year DM.
Yes, sir.
Okay, we'll share the screen. Is my screen visible to you?
Yes, sir.
Yes.
Okay. Now start. Said, you can start.
22-year male, studied up to 10th standard. Informant is mother. Complaints of patient is bluish discoloration of skin and oral cavity from birth and breathlessness from 3 months of age. Worsened for past 3 weeks.
Okay. What are your thought process?
Age?
No.
Age is 22 months.
22 years. 22
male.
years male. 22 years male. It is 22 years. It's a male patient. Male patient. S is the name of the patient. 22 is his age and he's a male patient.
Yes,
So
yes.
from the listening to the story, what are your thought process?
As the complaints started from the birth and complaints, so it's probably a congenital disease.
Why did you say
And,
probably?
So it's a congenital disease.
Yeah, you make a positive statement. It is a congenital cyanotic heart disease. It's blue. The baby
Congenital and
oral cavity
cyanotic heart disease.
So it is a cyanotic congenital heart disease. Very good. Yes. What may be the pathophysiology?
It can be, sir, because it is from birth, so it can be related to either abnormal arterial connections to the ventricular cavity, or it can be extracardiac related to some atrioventricular arteriovenous connection in the extra cardiac in the pulmonary.
Okay. Now, what are the pathophysiological abnormalities which can lead to cyanotic congenital heart disease? Abnormal physiology.
So at birth, cyanotic heart diseases that
Not at birth. I'm just asking a question in general. What are the physiological abnormalities which can lead to cyanosis, which may be the cyanotic congenital heart disease? How it can be classified based on the physiological involvement?
So cyanotic heart disease can be classified as either increased pulmonary blood flow or reduced pulmonary blood flow.
That's not the classification. First classification is not that. Any one of you?
Sir, Fallot's physiology?
Okay, VSD PS physiology. Better to say VSD PS physiology. Okay, right, very good.
Sir, then transposition physiology?
Very good. Transposition physiology.
And sir, admixture physiology?
Very good.
And sir, Eisenmenger physiology, sir?
Yes, pH physiology. Okay, right. And finally?
Then sir, miscellaneous group, sir?
Yes. Which are few conditions can you mention? Miscellaneous. It can be Epstein's anomaly or pulmonary arteriovenous fistula, or this can also give rise to cyanosis. So, so when you look at pathophysiology, you have to think of either in which category this patient belongs to. Either it is a transposition physiology, VSD PS physiology, admixture physiology, whether it could be a pH physiology, or whether it is a miscellaneous condition. Can you mention what is really happening in these situations? Can you say? Can you mention few admixture physiology? What is meant by admixture physiology? And can you mention few conditions where there is admixture physiology?
So admixture physiology, single ventricle.
Now, first you should define it. What is admixture physiology?
So admixture physiology means the arteriovenous blood is getting mixed either at the cardiac level or the pulmonary level.
Artery venous blood. Why did you say artery venous blood? Why did you use the word arteriovenous blood?
So systemic and
Yeah, systemic and
the venous bloods.
no, systemic venous blood. Systemic and the pulmonary venous blood
Pulmonary venous.
will come to at least one chamber where it is totally mixed.
Yes.
Examples? Mention examples. Examples of admixture lesion where one chamber receives all the venous drainage, both pulmonary as well as systemic, and gets mixed up. Any one of you?
TAPVC, sir.
TAPVC, very good.
Sir, in the arterial level, sir, TAPVC or any fistula, AB fistula or coronary Cameron fistula, sir?
No. That is not admixture lesion. For admixture lesion, all the
Truncus arteriosus.
truncus arteriosus, very good.
Then
Single ventricles.
Single ventricle, very good.
Common atrium.
Common atrium. Yes, these are the first
DORB, sir. Yeah.
DORB is not a admixture lesion.
Okay.
So these are the four, and you can include tricuspid atresia also, where the whole blood is coming to the left ventricle. So the conditions in which there are admixture physiology are one, total anomalous pulmonary venous drainage, single atrium, single ventricle, truncus arteriosus, and tricuspid atresia, where there is admixture of the whole venous blood, both the pulmonary as well as venous systemic venous blood coming together in one chamber. Okay, that's a admixture physiology, right? Transposition physiology.
The transposition physiology, sir, it's like the transposition of great vessels.
Yes, and also transposition of
8 ventricles, AVV concordance, discordance, or arteriovenous discordance.
Transposition physiology means when there is a what do you mean by transposition? Transposition of great arteries. What do you mean by that?
The normal relation of the aorta comes right and anterior to the pulmonary artery.
That is not the correct thing. I agree with you. That is the anatomy. But when you are saying transposition, means that aorta is connected to
Arteries connected to the right ventricle.
yes, aorta is connected to right ventricle, and pulmonary artery is connected to the left ventricle. That is the in simple terms. That's what you should understand. When somebody says that there is a transposition, it means that aorta is connected to the right ventricle and pulmonary artery is connected to the left ventricle. When there is a corrected transposition, is there any difference?
Yes, sir. The ventricle also inverse along with the arteries.
Looping of the ventricle.
What do you mean by that? What do you mean by
LV is to the right of the RV.
LV is connected to the pulmonary artery and is anterior to the RV.
Yes.
RV is posterior and LV is anterior. That is what is happening in L transposition as well as in retransposition. Why it becomes corrected transposition?
Was there is atrioventricular discordance?
Yes, there is atrioventricular discordance also. Along with the ventricular arterial discordance, there is a atrioventricular discordance resulting in two discordance comes together and gets corrected. So the right atrium and the right atrium drains into the left ventricle, and the left atrium drains into the right ventricle, and because of that, what happens? The oxygenated blood from the left atrium drains into the right ventricle, and the right ventricle pumps into the aorta, and the oxygenated blood goes to the aorta. So there is a in corrected transposition, there is a atrioventricular discordance and ventricular arterial discordance. While in detransposition, there is only ventricular arterial discordance. Okay, the transposition physiology can be arterial transposition or it can be venous transposition. Sometimes the systemic veins can drain into the left atrium. Sometimes there can be total systemic venous connection, and that can give rise to cyanosis. So transposition can be both arterial as well as venous. Okay, right. Third pathophysiology.
VSD PS physiology.
VSD. Best example is
Top physiology.
tetralogy of Fallot, or it can be double outed right ventricle with the VSD PS.
Yes,
All these come under this category. Okay, any VSD PS physiology like double outed right ventricle, transposed great arteries, all come under this category. And then the fourth one is, of course, very easy Eisenmenger physiology, where there can be. Okay, so in this patient, we have just heard the story. What is your thought process, say?
It's a by birth congenital central cyanosis, congenital cyanotic heart disease, sir. With birth, so my probable.
What do you mean by congenital heart disease?
So congenital heart disease means, sir, it's a heredofamilial disorder which presents at the birth.
No, it need not be heredofamilial.
Or it can get.
What is the difference between congenital heart disease and hereditary heart disease? What is the difference between congenital heart disease?
Means, sir, there is a disease which occur as a result of embryonic malformations related to genetic abnormalities, which can have effect from the environmental factors also.
Yeah, it may not be always hereditary, but there is a thought process that the congenital heart disease also is hereditary. But the most important thing congenital heart disease is that it is present from
birth.
Then why do you want to say that this congenital heart disease is present from birth? Congenital heart disease means it's at birth the heart disease is there.
Yes.
Hereditary heart disease?
So hereditary heart diseases, sir, may be expressed later at later age also.
Yes, hereditary heart disease may not manifest at birth. It may be but they have got a transmission pattern. It may be an autosomal dominant transmission, or it can be sex-linked transmission. There is a transmission pattern. For example, hypertrophic cardiomyopathy is an autosomal transmission hereditary cardiac disorder, and it may not be present at birth. Usually, it manifests by about 10 or 12 years of age. When the rapid the growth spurt is there, the hypertrophic cardiomyopathy may manifest. So hereditary and congenital are two entirely different terms. Congenital means the heart disease is present at birth. It need not be hereditary disorder. Hereditary heart disease means there is a pattern of transmission, either autosomal dominant transmission, or it could be a sex-linked transmission. Whatever may be the thing, there is a pattern of transmission, and the heart disease may not be present at birth, and it can be it may manifest after a few years, or it may be later in life. Some of the hereditary heart diseases may be congenital. It may be present from birth itself. So, congenital means it is present at birth. Hereditary means there is a pattern of heredity, and it may manifest at birth sometimes, but most of the times it manifests after a few years of postnatal life. Okay, right. But what I want to know is that from the story you heard three things: that 22-year-old male, bluish discoloration of skin and oral cavity from birth, breathlessness from 3 months of age, worsened for the past three weeks. What are your thought process? But let us start from 22-year-old male. What is the most likely congenital heart disease pathophysiology or physiology? Somebody who survived up to 22 years.
Eisenmengerization probably.
Well, Eisenmenger can be considered, yes. But if you are Eisenmenger cannot be considered as a bluish discoloration from
at birth, yes, sir. Yes, sir.
So bluish discoloration from birth with surviving up to 22 years. What could be the pathophysiology? Or what could be the physiology of cyanotic congenital heart disease?
VSD PS physiology, sir.
Very good. It is VSD PS physiology. It is the VSD PS physiology which survives for a longer period. So in general, it is said that if a person cyanotic congenital heart disease survives beyond 15 years, almost 80% it is VSD PS. Tetralogy of Fallot like physiology. So whenever there is a 20-year-old male, you should start thinking that it could be a VSD PS physiology. So can this be tetralogy of Fallot? Say it.
So, yeah, from birth, sir, tetralogy of Fallot usually doesn't present at birth with cyanosis.
Yes, very good. Tetralogy of Fallot usually does not present with cyanosis at birth. What is the reason why tetralogy of Fallot is not cyanosed from birth? What is the reason? Why is the tetralogy of Fallot is not blue from birth?
Pulmonary vascular resistance is more.
I beg your pardon?
Pulmonary vascular resistance is more in neonatal first.
Pulmonary vascular resistance is more in?
Neonate pulmonary vascular resistance will be high, sir.
Okay. What is the pattern of regression of pulmonary vascular resistance?
It will be delayed in case.
In tetralogy of Fallot, why should it be delayed? It will be delayed only when there is a large pulmonary blood flow associated with the
Yes, yes.
left right shunt. Here
Yes,
there is a, it is more of a right to left shunt. So why should be delayed? What is the normal pattern of regression of pulmonary vascular resistance in a normal baby who is born? What is the pattern of regression of pulmonary vascular resistance normal in a normal child? Any one of you? What is the normal pattern of regression of pulmonary vascular resistance in a normal child? A child is born, then how does it regress?
It is involution of the pulmonary pulmonary vascular.
Any one of you? How does it? Any one of you who would like to volunteer to answer this question? What is the pattern of regression of pulmonary vascular resistance in a newborn baby? What happens when the child takes the first breath?
The expansion of the lungs causes the expansion of the pulmonary. There will be increased flow.
You are right. When the lung expands, when the child cries, the lung expands, the pulmonary vasculature is opened out, the capillaries are opened out, everything is opened out. So that will immediately reduce the pulmonary vascular resistance. And with the first breath, the pulmonary vascular resistance drops almost by 50%. It's 50% drop in pulmonary vascular resistance as the child takes the first breath. And the remaining 50%?
There is involution of the vasculature, vascular.
Over a period of? What is the period during which the pulmonary vascular resistance can regress in a normal person and may reach near about the adult pattern?
Up to 6 to 8 weeks.
That is too long. No, much shorter.
48 hours.
No, not 48 hours. That is too short. It is usually about 2 to 3 weeks. Mostly it is about 2 weeks. The pulmonary vascular resistance drops by 50% when the child takes first breath. Then the child cries and takes the first breath. It drops by 50%, and over a period of next 2 weeks, it drops subsequently and reaches the adult pattern. The same pattern can follow in tetralogy of Fallot also. But my question is, why are you saying that tetralogy of Fallot patients are not usually cyanosed at birth? There are two mechanisms postulated. One, there is a PDA, the patent ductus arteriosus may be there at birth. It may close, it may take some time to close. And so through the PDA, the lung may get some extra blood, and that may keep the cyanosis at bay. And second, there is a fetal hemoglobin in these patients. It may be there, some degree of hemoglobin may be there even up to 2 years. And the fetal hemoglobin oxygen dissociation pattern is different from the adult hemoglobin. And that also helps in lack of cyanosis in a patient with tetralogy of Fallot. So patients with tetralogy of Fallot are unlikely to be cyanosed at birth. They are cyanosed only at a later life. It may take about a few months before they, or maybe a few weeks before the child becomes cyanosed. But of course, in a very severe form of tetralogy of Fallot, maybe something like almost pulmonary atresia or severe form of tetralogy of Fallot, sometimes the baby may be blue at birth. But most of the patients with tetralogy of Fallot, They are not blue at birth. So what are the cyanotic congenital heart disease where the baby can be blue from birth, maybe blue from birth? Say it.
Yes, sir. Sir. TGA, sir.
Transposition physiology and
TAPVC.
Yeah, admixture physiology.
Yes. Sir.
So these are the two situations mostly, and also you may also include large pulmonary artery venous fistulas can be cyanosed from birth. So you have to think of a possibility of with cyanosis at birth. That is a story given, and that may make you start thinking that it could be a transposition physiology or it could be a
Admixture physiology.
Admixture physiology. And also you should think that there may be associated VSD PS, because
Yes, sir.
usually only when the PS is there, then only child will have longer life expectancy. Otherwise, most of these patients, because if there is a large pulmonary blood flow, and these patients can quickly, they can develop left ventricular failure, they may develop recurrent pulmonary, recurrent lung infection, and these patients can deteriorate quickly, and most of them die before the second decade. But patients with VSD PS, when the child is living up to the third decade, you must always think of the strong possibility of VSD PS. So whenever you are thinking VSD PS, what is the most important clinical finding that you will look for in auscultation?
So whether the chest
Single
is
S2.
silent or it's chest is silent or having murmur.
Yeah, that's
Single
Single
heart
is-
sound.
You should carefully look for ejection systolic murmur in the pulmonary area. So when a cyanotic child, the most important auscultation you should look at is there a ejection systolic murmur in the pulmonary area, or anywhere in the pulmonary area or in the aortic area, wherever there is an ejection systolic murmur. If you are having an ejection systolic murmur in a patient with cyanotic congenital heart disease, it is always pulmonary stenosis. If there is no murmur, there is no ejection systolic murmur, then it could be a pulmonary atresia physiology. Then you should carefully look for what?
Collaterals we have to.
Yeah, collaterals. So then collaterals are detected by
So continuous murmurs maybe.
continuous murmur. You should look for continuous murmur. Which are the areas where you will specifically look for continuous murmur?
So at the upper back area and
Upper back area, and also
at the axillary areas.
Infrascapular area, and the more than infraaxial area, you may be able to pick a continuous murmur in infraclavicular areas.
Yes,
Upper part of the back and infraclavicular areas are classically the sites where you can get continuous murmur. But you must auscultate all over whether the patient is having continuous murmur. If the patient is having continuous murmur, you can diagnose that the patient is having collaterals, and a pulmonary atresia must be a possibility. Okay,
yes.
So here looking at the symptom of the patient, you should think that the first is bluish discoloration of the skin and oral cavity from birth. The patient is 22 years, so you are thinking of a VSD PS situation, and also either admixture physiology or transposition physiology. Third symptom, second symptom, breathlessness from 3 months of age. What does that mean?
Patient is failure. Actually.
Failure. Okay, the patient is in heart failure. So failure means is it a VSD PS situation or a high flow situation?
It's high flow situation.
It's a high flow situation. Breathlessness from 3 months of age tells you that it may be high flow situation. So here is a paradox that you are thinking that it is a VSD PS admixture lesion or a transposition physiology, but at the same time the child is breathless from 3 months of age. So that makes the history little confusing, but still I would say that 22-year-old male, you should always entertain the possibility of VSD PS. Okay.
Yes,
so now we will consider these possibilities from the history, initial part of the symptom. Let us look at the history of the patient. Okay, say it.
Yes, sir.
Any other point anybody wants to raise? We can say, see that. Any points you want to raise after hearing the symptom? You should start thinking by when you see the patient, and also when the patient is complained to you, what may be the few symptoms, because that will help you to ask more questions to the patient, as well as what to look for in the clinical examination.
Yes, sir.
So now From the symptom the patient has given, we have thought that because the patient is 22 years of age, we are considering a possibility of VSD PS. When the patient is having cyanosis at birth, we are thinking possibility of a transposition physiology, or it could be a admixture physiology, or it could be pulmonary arteriovenous fistula, large pulmonary arteriovenous fistula. Breathlessness from 3 months of age, that confuses us, because breathlessness in the early part of the life usually indicates high pulmonary blood flow, patient developing left heart failure. And Western for the past 3 months can be due to respiratory infection, whatever it is. That's a different thing. Okay, now let's go to the history of present illness.
Yes, sir. So, history of present illness is, patient was born of a non-consanguous marriage. He was the first child, and full term delivered through LSCS due to non-progression of the labor at that time, and cried immediately after birth. Birth weight was
firstborn male baby. What is the condition that you should suspect?
Rubella.
Beg your pardon?
Maternal rubella syndrome.
No, not maternal rubella. But firstborn male baby. Any cyanotic congenital heart disease should cross your mind.
Down baby?
No, it is not a down baby. Male babies have got a higher chance of transposition of great artery.
TGA.
It is much more common in male babies. They are firstborn, and the babies have got a good growth also. They are usually sometimes overweight. What is the reason?
So diabetic mother gets more TGA?
No. Diabetic mother does not have more TGA. But diabetes mother get overweight babies. That is right. But they need not have TGA. They can have hypertrophied intraventricular acceptance sometimes, and which may regress after about few months. How does the baby get oxygenated blood? Here there is an interesting physiology that the oxygenated blood, which ventricle gets the oxygenated blood in patients with in a baby? Where is the oxygenated blood coming from?
So from the placenta
Umbilical
to the
vein.
iris.
The placenta,
Umbilical vein.
The umbilical veins, it drains into the IVC, and it comes to the right atrium. So then it crosses to the left atrium through the foramina vein, and that can go to the systemic circulation. But here, the oxygenated blood which is coming to the right atrium, right ventricle, is pumped into which vessel?
Aorta.
Aorta.
So aorta can directly get oxygenated blood, and it is one of the explanations given that most of these the transposition babies have got a much better growth because they have got oxygenated blood going over. And so very often these babies have got a higher birth weight also. So firstborn male baby, higher birth weight. Okay, go ahead, say it.
Yes, sir. At that time,
baby does not have higher birth weight, 3 kilograms only. That's not a big.
Yes,
if it is 4 kilograms, we would have thought that it is a higher birth weight.
Yes.
Okay. Yes.
Yes. Mother noticed the bluish discoloration of skin of the limbs and of the mouth and tongue on the first day of the baby. She brought this to the notice of the pediatrician, who, after examination of the baby, said that everything is normal.
What do you mean by that? What do you mean by that? Interpretation.
So sometimes during initial period, sir.
No. This story is. This brought to the notice of the pediatrician, who, after examining the baby, said that everything is normal. What is your?
It means there is no murmur at that time, sir.
Very good. There is no loud murmur, because usually pediatricians, when they examine, they look for a murmur, and it obviously means that this child did not have a loud murmur at birth. So that is a point against the diagnosis of
An obstructive lesion as well as regurgitant lesions.
Yeah, but obstructive lesions is the one which can give rise to more easily detectable murmurs. Yes. So that makes us a little jittery to diagnose VSD PS, because a pediatrician examined the baby and said that there is no heart lesion. Usually pediatricians mostly look for a murmur, and if there is no murmur, they consider that the heart is considered to be normal. So this particular point will make us start thinking that there may not have been a VSD PS situation. So we should think what actually has happened to the patient. Okay, go ahead. Every sentence you should think, then only you can come to a correct diagnosis.
Yes, sir.
Okay, say.
Then initially, baby was feeding well. After about 3 months, the child started developing breathlessness during feeding. He used to cry during feeding, which made him blue. The child had head sweating associated with feeding. Mother noticed that the child had suck rest suck cycle. He had associated swelling of both lower limbs. So the parents took the child to a nearby pediatrician who referred the child to a cardiac center where the child was diagnosed to have heart disease and was told to the parents that he need an emergency surgery.
Okay. Interpretation.
So child was in failure. Actually, due to failure, he got fatigued during feeding, and after
child has got failure. Failure means what is the? Is it a reduced pulmonary blood flow or increased pulmonary blood flow?
Increased pulmonary blood flow.
Increased pulmonary blood flow. What are the symptoms of a baby who is developing left heart failure?
So in feeding baby, sir, baby will take not be able to take continuous feeding. He will take breaks during the feeding.
Okay, there will be
sweating
cycles. Okay, yes, 1, 2.
And failure symptom with this baby is
no, not this baby. In general, I am asking what are the symptoms which will make you think that child may be in heart failure or child had left-sided heart failure.
The forehead sweating.
Head sweating, yes, very good.
And sir, the baby will be better in lap, mother's lap, like patient, like orthopnea, like.
Baby will be better in upright position.
Upright position.
Not in lap. The child will be better in the shoulders rather than in the lap. Child will prefer to be in the shoulders of the mother rather than in the lap of the mother. Okay, very good. Yes, and the point. One important point you have not mentioned. That is the one which very often the mother or grandmother takes the baby to the doctor. Of course, suck reflex cycles also is important. And this tachypnea, child will be tachypneic, and the grandmother immediately noticed that child is breathing much more than normal.
Yes,
and unexplained crying. The child, when the sleeping, suddenly cries, wakes up and cries, and the unexplained crying is another, because child feels breathless and child cries immediately. So these are the few symptoms. So to repeat: 1, tachypnea; 2, head sweats; 3, recurrent respiratory tract infection; 4, the unexplained crying; 5, the child prefers an upright posture. All these are features which make you think that child may be in left heart failure. Okay, right? Yes. So here we have got every reason to believe that the child is having features suggestive of left heart failure. And why does the child develop left heart failure when there is an increased pulmonary blood flow? Say it.
Sir, in conditions of increased pulmonary blood flow, there will be pulmonary arterial dilatations that will cause the compression of the bronchioles, terminal bronchioles, and stasis, which leads to nidus of infection in the bronchioles.
No, I am not asking about an infection. I am asking how can a patient with increased pulmonary blood flow develop left heart failure?
So, increased blood flow will be leading to the LV overload due to which.
Yes, very good. When there is an increased pulmonary blood flow, that will result in LV volume overload. And in a newborn baby, the ventricle is not prepared to handle such volume overload. That will result in elevated left ventricular and diastolic pressure, left atrial pressure goes up, pulmonary congestion, and the patient will have features of left heart failure. So it is because of the volume overloading of the left ventricle. Okay, right? Yes. Okay, right. Now go ahead. Any other questions that somebody would like to ask, or any clarification required? Okay, right. Go ahead, Said.
Sir, due to the financial constraints, the parents declined the surgery, and for the next 6 months, the child had recurrent hospitalizations for episodes of LRI, and at 8 months of age,
Recurrent
he
respiratory,
underwent a balloon.
how will you interpret recurrent respiratory tract infection, lower respiratory tract infection? That's one feature of increased pulmonary blood flow. And in general, even though there is no standard criteria, in general, what is the criteria that you will apply to diagnose recurrent respiratory tract infection?
So recurrent respiratory tract
More than
infection,
6 in 1
3
year.
in 1 year or 5 in 2 years. One of them have been hospitalized or IV antibiotic needed.
No, what did you say? Can you repeat once more?
Sir, more than 3 time infection in 1 year, or sir 5 time in 2 years, and one of them required IV antibiotics or hospitalization.
Right, okay. You're mostly right. But what do you mean by 1 year and 2 years? Is it the age of the patient?
No, in 1 year, the number of lower respiratory tract infection 3 times.
How will you know from the story it is a lower respiratory tract infection?
Okay, sir.
What is the frequency of respiratory tract infection in a normal baby in the first year? In the first year, how many times a normal baby can have respiratory tract infection? Because baby's resistance is very low, and so it is up to 4 to 6 respiratory tract infections are possible in a baby during the first year of life. And most of these respiratory tract infections are only minor upper respiratory tract infection and settles down. And when the baby needs a hospitalization, at least for 1 time, and if there are 2 times, then it is very highly suggestive, and requiring IV antibiotics, hospitalization IV antibiotics is suggestive of recurrent low respiratory tract infection. I would say that more than one or more. I would recommend, if there are 2 hospitalizations, then you are sure. If there is 1 hospitalization, that also is suggestive. And you can also take two years together, and if there are more than 5 infections which you think is most likely lower respiratory tract infection, and it is more than 2 hospitalizations for intravenous antibiotic administration. So there is some difficulty, but then if there is a definite story of hospitalization, then you are very clear that the child is having lower respiratory tract infection. So here the child had a recurrent hospitalization for episodes of lower respiratory tract infection. So obviously the child has got evidence of increased pulmonary blood flow and left heart failure and recurrent respiratory tract infection. Okay, right? Yes.
Next, at 8 months of age, he went a balloon procedure from the cardiac center.
So what do you think there may be the possibility?
Sir, they might have done pulmonary valve balloon dilatation.
Balloon atrial septostomy.
The 2 possibilities. One, you are also right that both are right. That they might have done a opening up for the tidally stenosed pulmonary valve, or they might have done a balloon septostomy, or establishing a good shunt for a patient with transposition of great arteries. Okay, right. Both should be kept in our mind. Yes, go ahead.
Following this procedure, he had a slight improvement of breathlessness, but the bluish discoloration persisted.
Okay. So what is of these 2, which one will you say, which one will you prefer? Is it would you prefer to consider that this is a opening up of the pulmonary valve, or do you think that the patient might have undergone a atrial septostomy?
Atrial septostomy.
Why did you think that?
Because it will lead to right to left shunt, which will make the bluish coloration persistence.
No, but you said that it can be opening up of the pulmonary valve.
Yes, it is.
Of the 2, which one you think is more likely?
Balloon septostomy.
Reason?
Reason, sir, through balloon septostomy, they will be creating a right to left shunt.
No, that is right. That I agree. In transposition of great arteries, you are doing that. But I am saying that of these 2 procedures, why did you prefer that this could be a atrial balloon septostomy rather than opening up of the pulmonary valve? Reason.
Sir, our history is suggestive of increased pulmonary blood flow.
Very good. There is a history suggestive of increased pulmonary blood flow.
Yes.
And when you are thinking of tight pulmonary stenosis, you cannot have
Yes, so pulmonary blood flow will not be there.
increased pulmonary blood flow. So if you are considering the story is correct, then you have to think that the patient must have undergone a atrial septostomy rather than opening up of the stenosed pulmonary valve.
Yes.
Because the history is more suggestive of increased pulmonary blood flow. And if the patient is having a very tight stenosed pulmonary valve, unlikely to have symptoms suggestive of increased pulmonary blood flow.
Yes.
Okay, right. Yes, go ahead.
His both physical and mental milestones of development were significantly delayed.
What do you mean by physical and mental milestones?
Sir, physical and scholastic milestones were delayed, sir.
No, what are those? Physical milestones, mental milestones? Give some examples.
The mental milestones is more of scholastic performance.
Yes, like?
Delay in progression from one standard to other standards and
in school. This is you are taking the story in a baby who is only few months.
Like social smile, recognizing mother.
Yes, very good.
Recognizing familiar faces.
Yeah, those are the ones which are mental milestones are social smile, recognizing the mother, recognizing a stranger. All those things are come under. Or repeating a word which was told to the baby. All those things come under
mental milestones.
Physical milestones.
So like turning of the baby, sitting, standing, taking first step.
Yes, all these things, standing, sitting up, crawling, standing up, taking few first steps. These are all physical milestones. So both are delayed. Okay, right. Yes. Okay, go ahead.
At the age of 1 year, he had fever, seizure, and weakness of left upper limb. He was diagnosed to have pus in the brain and had hospitalized treatment.
So what does that mean?
So, he developed brain abscess because of the cyanotic disease.
Why should they develop the brain abscess because of the cyanotic disease?
The right to left embolism, sir.
Yes, so
right.
If there's right to left hand, what is the problem?
So the infection from the limbs have gone to through the paradoxical embolism gone to the brain, sir.
Very good. Usually the lower limb is a lower limb blood always is a source of infection. Yes, and normally if there is an infection gets in through the lower limb, it is always filtered at the lungs and it does not proceed to brain. But in a patient who is having a right to left shunt, it can cross, it can short circuit the lungs, go to the left side and can go to the brain and can give rise to infection in the brain resulting in brain abscess. Okay, right. Yes. So brain abscess is a feature of cyanotic congenital heart disease. Okay, right. Yes.
Sir, good evening, sir. Monica here. Hello.
Oh, yes.
Just sorry to interrupt, sir. This way we can answer this question. It's very frequently asked because the filtration at the lung levels is absent in cyanotic patients.
Yeah.
So that is the reason why they get brain abscess.
Yeah, if the lung is short circuited or the filtration does not
bypassed.
Yeah, it's or bypassed and that will result in the infection directly going to the systemic circulation and to the brain, resulting in brain abscess.
Yes.
Okay.
Yes.
Okay.
Thanks.
Thank you, Monica. Right. Okay. Go ahead.
From the age of 1 to 2 years, he had multiple hospitalizations for respiratory infection. He started walking from the age of 2.5 years. Mother noticed that while walking, he squats to get relief of breathlessness.
What do you mean by that?
He developed squatting episodes because of cyanosis he developed.
No, because of the cyanosis, you cannot develop squatting episodes. You have to explain.
Cyanotic episodes.
What situation you give the child can squat, and also you must explain what is the benefit of squatting. Why do squatting is a feature of a high flow situation or a low flow situation?
Low flow situation.
Low flow situation.
Yes.
So here is a paradox that we are thinking of high flow and the baby is having squatting.
Yes.
So squatting, what are the benefits of squatting? And also tell me whether you can have squatting in high flow also.
So we can have a squatting sometimes in high flow situation also, because sir, because of the squatting, sir, the preload will decrease.
Oh, preload decrease. Why should the preload decrease?
Sir, the venous return, because of the squatting.
Because of squatting?
So the venous return from the lower limb will decrease.
Yeah,
from the abdomen it will increase.
Yeah, so ultimately between these two, the lower limb return is cut off and the abdominal compression will result in an increased venous return from the abdominal viscera. Ultimately, will it give rise to an increase in the venous return or a decrease in the venous return?
So, it will increase, sir, because abdominal viscera it will come out.
Yes, it is thought that there is an increase in the venous return because the squeezing of the abdomen resulting in significant venous return from the abdominal organs. Okay, right, yes. So there is an increase in the venous return. And what are the mechanisms by which a squatting benefits a cyanotic child? That's my question.
Yes, sir. A cyanotic child is benefited because, sir, the limb saturation is lower, whereas the abdominal viscera, the blood coming is saturated because it is not being utilized, like maximum blood coming from the kidney.
Yeah, very good. The kidney is a very little utilization of oxygen, and the renal vein blood is almost 85 to 90% saturated in a normal person. Okay, right? Yes.
Increase in afterload.
And sir, there will be a increase in the systemic vascular resistance also. Okay. As a result, sir, right to left shunt will decrease.
Yeah, that's right. Now, what is the benefit of more oxygenated blood coming to the right side?
Sir, ultimately that blood is going to the aorta.
Oh, not aorta. A part of that blood is shunted from right to left through the communication.
Sir, overriding or
whatever it is, there is a communication which will result in a right to left shunt. So right to left shunt. If the blood coming to the right side is more oxygenated, then more oxygenated blood is going to the left side, and so desaturation becomes much less. So because of the more oxygenated blood coming to the right ventricle, right side, even when the shunt takes place from right to left, the deoxygenation of the systemic circulation will be relatively less. 1. 2, that what you have said is right. When the squatting gives rise to increase in the systemic vascular resistance, thereby reducing the right to left shunt. So because of these two reasons, squatting benefits the cyanotic child, and mostly it occurs in low pulmonary blood flow group. But as Saroj has rightly pointed out, there has been descriptions that even a patient with Eisenmenger can benefit by squatting. So that you can keep in mind. Okay, right. Yes, go ahead. Very good.
The bluish discoloration of skin and mouth gradually increased. He continued to have breathlessness and bluish discoloration of the body. At the age of 10 years, he was taken to another cardiac center where a second balloon procedure was attempted, but it was not successful. Child remained significantly symptomatic. Parents were told that no further interventions are possible. He had mild improvements with the drug.
Okay, right. Yes. We'll go ahead with we'll complete the story and then discuss. Okay, right. Yes.
From 10 to 15 years, frequency of hospital admission reduced. However, he remained in NYHA class 3 symptom, but no history of PNT. At 15 years of age, he developed swelling of both elbow and knee joints. Fluid was aspirated from the knee joint. He also had headache and blurring of vision. When his blood was tested, he was found to have significantly elevated hemoglobin, for which he underwent removal of blood. For past 6 years, he is getting repeated swelling of both the legs, which is temporarily relieved by his medications. He also had multiple episodes of blood removal. He had an episode of hemoptysis 2 years ago. No history of blackouts or graying of vision. No
hemoptysis, any episode of hemoptysis, how does it help you? In what conditions do you get hemoptysis?
So any pulmonary infarction happening?
Eisenmengerization?
Yes, eisenmengerization can give rise to hemoptysis. Mechanism? What are the pathological changes of pH?
Pulmonary infarction happens.
Pathological changes of pH, grade 1 to grade 4. When the patient develops pulmonary arterial hypertension, need not be, I'm not, of course, Eisenmenger is one in which it is classically described. It can occur in primary pulmonary arterial hypertension also. And this is known as Edward Heath classification of pulmonary arterial hypertension pathology, which is originally it was grade 1 to grade 6, but we now know that it is a grade 1 to grade 4 because grade 4 to grade 6 is interchangeable and there is no point in adding a grade. So grade 1 to grade 4. Can any one of you tell me what is the pathology of pulmonary arterial hypertension grade 1 to grade 4?
The first is congestion.
Congestion.
Obliteration, proliferation and fibrosis.
Tell me what is grade 1 change?
Sir, in grade 1 there is a medial hypertrophy of small pulmonary artery.
Medial hypertrophy, very good. Grade 2?
Sir, second, sir, in medial hypertrophy plus interval proliferation is there. Sir.
Very good. Yes, grade 3.
So on grade 3, sir, there is fibrosis of intima. And also there is a lumen of pulmonary artery become small, means occlusion of the pulmonary artery lumens.
Yeah, there is fibrosis. There is a fibrosis and intimal and initial fibrosis. Okay, very good. Yes. Grade 4.
And there is a plexiform lesions and muscular arteries, sir.
Very good. Arteriopathy. You can use the word arteriopathy, which includes plexiform lesions, arterial aneurysms, thrombus formation. All this can happen in stage 4 of the. Very good. What is your name?
Yes, sir. Eknath, sir.
Eh?
Eknath, sir.
Eknath. Actually, I was looking for you. I think you joined a little late.
No, sir, actually, yeah, I was in traveling, sir, basically. So,
actually, I thought I would ask you to discuss the case because
next time I will do, sir.
Very good. So, yeah, these are the 4 stages of pulmonary arterial hypertension. In stage 4, you can get a recurrent hemoptysis because the arterial aneurysm, the malformations, the clot formation, all can lead to hemoptysis because bleeding can occur and that will result to hemoptysis. Okay, that's one mechanism. Second mechanism. Second mechanism.
The recurrent infection can cause, sir?
Very good. Like a recurrent infection can give rise
pulmonary infarction.
Yes, recurrent infection can go. How can they have pulmonary infarction when there is polycythemia? When there is when the hemoglobin goes above 20 grams, there is always a risk that can result in the thrombus formation and can give rise to pulmonary infarction. And also these patients can have
embolism.
Patients can have aorta pulmonary collaterals flow, and some of these collaterals can give a rupture and can give rise to hemoptysis. So the hemoptysis can occur both in high flow situation as well as in low flow situation. So you must know the mechanism of hemoptysis in a patient with cyanotic congenital heart disease, which includes the Eisenmengerization, then recurrent infection, 3, the aorta pulmonary collaterals, and also pulmonary infarction secondary to thrombus formation because of the viscosity of the blood. The hemoglobin, when it is more than 20 grams and packed cell volume is more than 60%, there is always a risk that the patients are predisposed for thrombus formation. Okay, right? Yes. So you had an episode of hemoptysis. Yes. Go ahead.
For the past 3 weeks, he is having dyspnea even at rest. He also developed edema of both the feet, which came down with treatment. No history of decreased urine.
What is the edema of both leg means? What is your interpretation?
Patient is in congestive heart failure, sir.
Yes,
right heart failure.
Right heart failure. Patient might have developed right heart failure. Very good. Okay, yes.
And no history of decreased urine output, use of NSAIDs or exposure to COVID infection. No history suggestive of rheumatic fever at any time.
Okay, right, yes. Okay. Oh, go ahead.
As for the antenatal history, sir, there is history of attempted abortion with some medicines at 2 months of gestation. No history of maternal infection during pregnancy. It was a LSCS at full term and weight was 3 kgs of the baby. It was a non-consanguineous marriage. Parents were healthy. One young sister, no heart disease in the family. Personally, patient was a non-vegetarian with no habits or addiction. Treatment, he has undergone 2 balloon procedure at the age of 8 months and at 10 years of age. At present, he is on 4 medicines. One is iron tablet, one is for the joint pain. Third medicine causes increased urine output. He does not know about the 4th medicine. He belongs to a low socioeconomic status.
Okay, now you discuss the case. Discuss till the time we can come very close to the diagnosis, so that when we do the clinical examination, it becomes easier for us to decide what to look for and what not to look for.
Patient is born is cyanotic since birth with
the child is cyanotic from birth. So what does that tell you? Most likely it is a
congenital cyanotic heart disease.
No, that is right. Congenital cyanotic heart disease. After that, what variety?
It's probably VSD PS physiology.
Oh, why did you say that VSD PS physiology for the child is cyanosis from birth?
Yeah, either transposition or admixture.
It should be transposition or admixture, or rarely a large pulmonary arteriovenous fistula also can have cyanosis at birth. So you cannot go for VSD PS. VSD PS usually the cyanosis is delayed.
Yes.
So you should think of the possibility of transposition physiology or admixture physiology. Okay. Yes. Out of these two, which one you prefer?
So admixture physiology.
Why? You should take every point into consideration. He has undergone 2
balloon septum.
Yeah. So in what admixture physiology you do balloon septostomy? So the story that he has undergone some interventional procedure makes you start thinking that this could be more likely a
transposition physiology.
Transposition physiology.
Yes,
you are thinking of transposition physiology because he has undergone 2 procedures. Okay, is it the next question that we have to ask is that, so we have thought that this is patient is having a cyanotic congenital heart disease, most likely a transposition physiology based on the evidence that we have. Is it a high flow situation or low flow situation?
A high flow situation.
Most likely high flow situation because there is history of recurrent respiratory tract infection, which is suggestive of left heart failure, all those. Yes. But what is the odd point for the high flow situation?
Squatting.
Squatting episode. And second, it cannot be a squatting, need not be a neutral point. Sometimes it's not a very striking point. Mother has just said that. So there is a possibility that sometimes patients with Eisenmenger syndrome also can have occasional squatting. All right, yes. But survival up to 22 years. Most of the patients with cyanotic congenital heart disease with a high flow situation, they usually succumb during the before they reach the 2nd decade. So he has survived up to 3rd decade. Most of the patients who survive up to 3rd decade will have VSD PS. So in our examination, we should be very careful to pick up the ejection systolic murmur in the pulmonary area. We should be very careful to look for that specifically because he has survived up to the age of 22 years. So, but from the story, we have to think that it's more likely to be a high flow situation. Okay. So,
his survival is with surgery procedure. Till we should consider this point. It's only with the procedures that.
Even then, even if the procedure is there, but yeah, the survival in a patient with increased pulmonary blood flow, cyanotic congenital heart disease with increased pulmonary blood flow, most of the times is usually only up to the early second decade. That's an odd point. So any patient who is more than 15 years of, in general, is that any patient who is a cyanotic congenital heart disease more than 15 years usually will have VSD PS. The survival is mostly VSD PS when they exceed 15 years. 80% are VSD PS. But see, there is nothing like 100%. So we can still keep our mind open. But from the story, we will like to think that is a transposition physiology, increased pulmonary blood flow, and he had few complications. He had two interventions, and he had a brain abscess. All these things go for that does not tell us anything special, but it goes for cyanotic congenital heart disease with a right to left shunt. Okay, right, yes. Okay, anything else? Any other conclusions can we draw from the story? What is the explanation for this joint symptoms?
There may be gout, sir.
There may be
gout, sir. Increased uric acid.
They can have gout. So, okay, the one possibility is gout. Very good.
Sir, hypertrophic osteoarthropathy can be there.
Very good. Very good. Excellent. Excellent, Suraj. Excellent. Two possibilities that you can think of is that whether the patient is having gout, and second is hypertrophic, pulmonary hypertrophic osteoarthropathy, where the clubbing, severe form of clubbing can have lesion extending proximally and joints can be involved. Very good. Excellent. Okay. Now, any other point, or we'll go to the physical findings. Said, any other point you would like to discuss? Okay, physical findings. Okay, right, yes.
On general examinations, the patient is conscious, cooperative. There is no syndromic features. Weight is 35 kg, height 155 centimeter. Mild dyspnea was present. Respiratory rate is 18 per minute. Central cyanosis present, which is severe. Saturation, SpO2 75%, all four limbs.
What is the level of oxygen saturation at which patients can have cyanosis?
Below 88%.
No, not below 88. If there is a polycythemia, around about 85%, you can have cyanosis. Yes. But in a person with a normal hemoglobin, I think it has to drop below 80% to have cyanosis. Usually cyanosis is present when there is polycythemia, when it drops to about 85%. And most of the patients with cyanotic congenital heart disease will have polycythemia. So 85% is a correct thought process. Okay, right. Yes, go ahead.
There is pan-digital clubbing present, kyphoscoliosis present, bilateral mild pedal edema present. The patient is afebrile without any stigmata of infective endocarditis.
Okay. Any additional information that we have from this physical finding? Patient is severely cyanotic. So what are the conditions in which patient can get severe cyanosis?
Eisenmenger.
Okay, Eisenmenger can give us to progressive severe cyanosis. Okay, yes.
And child of TOF.
Yes, severe patients with significant pathology of fellow. But in patients with significant pathology of fellow, as the age advances, usually the cyanosis comes down. Why? Say it.
Cyanosis comes down, sir, because patient prevent the development of significant cyanosis with squatting or squatting equivalents.
No. Squatting does not develop, cannot prevent progression of cyanosis. It can protect the baby when baby becomes deoxygenated, can improve the oxygenation of the systemic circulation or the oxygen supply to systemic circulation. But I asked a question in a patient with severe pathology of fellow. Sometimes the cyanosis can come down, and what may be the reason?
Collaterals.
Very good. Developmental aortopulmonary collaterals. When they develop aortopulmonary collaterals, that can result in cyanosis coming down. So that is one explanation for cyanosis coming down. Otherwise, mostly in patients with tetralogy philo, cyanosis can progress. Why? Because the
infant
more and more. As the age advances, the obstruction can become more. That will result in more right left shunt. The child can become more and more cyanosed. Okay, right. Yes, so the collateral flow will help to reduce the cyanosis. So that's something which can happen in a child with a low pulmonary blood flow. Okay, right. Yes.
So in CBS examinations,
in a patient with increased pulmonary blood flow, can the cyanosis come down? Or can cyanosis increase? What will happen in a patient with increased pulmonary blood flow?
Increased
pulmonary outflow obstruction can occur, then cyanosis can decrease.
Cyanosis can
decrease, like sir, in cases of outflow obstruction with the
in a patient with increased pulmonary blood flow, if the child is to survive, they should develop either a RV outflow obstruction over a period of time, or the patient should develop pulmonary arterial hypertension. When this happens, what happens to the left to right shunt or right left shunt, and what happens to pulmonary blood flow?
So then pulmonary blood flow will decrease.
Yes, pulmonary blood flow will decrease. And when the pulmonary blood flow decreases, what happens to cyanosis?
So it will decrease because here is a increased pulmonary blood flow situation. So patient in congestion.
No, that's not the reason. Whenever there is a decrease in the pulmonary blood flow, cyanosis will become more pronounced. The increased pulmonary blood flow always decreases cyanosis because more and more blood is getting oxygenated, and the cyanosis will be much less. But even in a situation where there is increased pulmonary blood flow, gradually if the pulmonary blood flow comes down, the child will become more and more cyanosed. So increased pulmonary blood flow initially may be less cyanosed, and as the child grows, the pulmonary arterial hypertension develops, or the pulmonary some obstruction somewhere maybe in the RV outflow, and that can result in less of pulmonary blood flow, and these patients can become more cyanosed. More blood gets oxygenated in the lungs, means cyanosis becomes less. So less of cyanosis is a feature of increased pulmonary blood flow, and as the blood flow comes down, the child becomes more cyanosed. Okay, right? Yes. So central cyanosis, severe cyanosis means that probably this child's pulmonary blood flow must be coming down. And this patient with increased pulmonary blood flow, what is the mechanism by which the pulmonary blood flow can come down? Say it.
Pulmonary hypertension.
Yes, pulmonary arterial hypertension. When they develop pulmonary arterial hypertension, ACN mineralization, that can result in less of pulmonary blood flow, and that is less of left to right shunt. The pulmonary blood flow comes down, and these patients can have more cyanosis. Okay, yes, okay, yes, go ahead.
Pulse rate was 78 per minute, regular, normal volume, normal character, no thickening of wall, all peripheral pulses felt, and no radial or radiofemoral delay.
Okay, right.
BP was 130 by 75 millimeters of Hg in the right upper limb, 130 millimeters of systolic blood pressure in right lower limb. JVP is not elevated above the sternal angle, and jugular venous wave pattern were normal.
Okay. Can you tell me if you cyanotic congenital heart disease where JVP examination can sometimes help you to diagnose the condition?
Sir, A wave prominent or A and V wave become prominent equal in ASD.
A wave becoming prominent in ASD. What is the condition when there's a prominent A waves in the neck? What is the condition and the child is cyanosed? What should you think of?
Tricuspid atresia.
Tricuspid atresia. Can you classify the tricuspid atresia?
tricuspid atresia can be divided in 3 groups, sir. And sir, each has been again divided into 3 groups. Sir,
Okay.
first is with the normally related great arteries.
Okay.
The second is with the malposed great arteries.
Okay. No, transpositional great, right? No.
Transposition of the great arteries.
Okay.
Normally, and the third one is and sir, A, B, C is there of these.
What is the third one?
Third one, sir,
Tricuspid atresia is classified into type 1, type 2, type 3. And each type 1 and type 2 has got 3 classes, ABC.
Yes, sir, ABC. Sir, first one is, sir, with VSD, and sir, second one is non-restrictive VSD, and the C will be
Any one of you, anybody knows what are the different types of tricuspid atresia? And about the, do you want to make any comments about the type of tricuspid atresia as far as the atretic valve is concerned? It can be 2 types. It can be fibrous atresia, where there is a fibrous membrane at the site of the valve and is atretic, no valve, or it can be muscular, where at the site of the valve it will be a muscular tissue and there can be no valve at all. And then it can be classified into 3 types: type 1, type 2, type 3. And any one of you would like to say about these 3 types of tricuspid atresia? Any one of you? Say it.
Sir, I will tell you again, sir.
Oh,
Sir,
okay.
type 1, sir, it is normally related great arteries.
Very
and
good.
sir, of which, sir, A is pulmonary atresia with no VSD, sir.
Very good. Excellent. Okay, right. Now you are corrected with it.
I forgot, sir. And second one is, sir, with the restrictive VSD.
Oh, and
Sir, there will be pulmonary stenosis will be present.
yeah, restrictive VSD with pulmonary stenosis. And this is the commonest variety.
Yes, sir. 1B is the commonest variety.
Almost about 65 to 70% cases are this category, type 1B, where there is a restrictive VSD and pulmonary stenosis. Okay. C.
Sir, C will be, sir, large VSD but no pulmonary stenosis.
Yes, then unrestricted VSD and no pulmonary stenosis. That is type 1, 3 categories. Type 2.
The type 2 has got a retransposition of the great arteries.
Yes.
And sir, again, ABC will be the same, sir.
Very good. ABC is the same pattern, but associated with transposition of great arteries. Type 3.
So type 3, I think L transposition of the great arteries.
L transposition or complex anomalies like L transposition or complete AV canal defect. So all these things come under the category of type 3 pulmonary atresia. So you must, all of you must know, because the examiner can ask you about tricuspid atresia and the type of tricuspid atresia and what is the commonest variety. Commonest variety is type 1B. Okay. And so when a patient with, if you are seeing a prominent A waves in the neck, you should think of the possibility of tricuspid atresia. But can you get tricuspid atresia?
Yes, sir. Also with sir, pulmonary stenosis with intact septum.
Pulmonary atresia, what did you say?
Pulmonary, pulmonary stenosis with intact interventricular septum.
But what it can give rise to what?
Sir, prominent A wave.
Yeah, I am asking a question. Can in a patient with tricuspid atresia, the airways need not be prominent, and if it is not prominent, I will explain it.
The presence of large ASD.
Yeah, if there's a large ASD, non-restrictive ASD can give rise to a situation where no prominent airways in the neck. But when there are prominent airways in the neck, you should think of the possibility of tricuspid atresia. 1, 2. What is the other condition you should suspect?
It's a tricuspid stenosis.
Okay, tricuspid stenosis as can occur in patients. Sometimes there is a abnormality of the tricuspid valve, which may be tricuspid stenosis, or it can be a cyanotic abstain. Okay, right, very good. Yes. Third point. Third one. Said, do you have a thought process? For the A wave to become prominent, what should happen? There should be an obstruction at the tricuspid valve, or there should be a difficulty to drain the contents into the
pulmonary
RV.
RV. So, what is the situation where the RA finds it difficult to empty its contents into RV?
The pulmonary atresia with intact septum.
Okay, pulmonary atresia with intact septum, or even severe pulmonary stenosis.
Yes, sir.
And if the severe pulmonary stenosis with restrictive ASD can have sometimes a significant cyanosis and a prominent A wave in the neck. Because when there is severe pulmonary stenosis, that will give rise to a severe right ventricular hypertrophy, and the right atrium may find it difficult to empty its contents into the right ventricle, especially if there is a restrictive ASD. And these patients can have sometimes prominent A waves in the neck and maybe also cyanosed. So these are the few conditions where you can get prominent A waves in the neck and cyanosis. They include pulmonary tricuspid atresia, tricuspid stenosis, then patients with intact interventricular septum with pulmonary stenosis. So that can also give us to severe prominent A waves in the neck. So A waves in the neck can be due to these conditions and may be associated with, and also in Epstein's anomaly where there is a atretic or rather Epstein's anomaly associated with stenosed pulmonary tricuspid valve also can give rise to prominent A waves in the neck. So prominent V waves in the neck. Condition, say it. Maybe with cyanosis, without cyanosis, prominent V waves in the neck. What are the conditions in which you can get prominent V waves in the neck?
Tricuspid regurgitation.
Ostium primum ASD.
Ostium primum ASD, very good.
Then RSOV2.
No, you tell the condition so that it becomes more clear.
Yes, sir.
First condition where you can have a prominent V waves in the neck is also when this patient is having tricuspid
regurgitation.
Second.
Sir, Gerbody's defect.
Okay, Gerbody defect. Okay, there is a LVRA shunt. Okay, right. 3.
And sir, ostium primum ASD.
Yeah, you can say that ASD with MR.
Yes, sir, ASD with MR.
Ostium primum ASD. Okay.
And sir, RSOV2.
RSOV2 RA.
RSOV2 RA, very good. Any other? Whether can be a
yes, sir, AV fistula.
There is a pulmonary artery venous, any artery venous, coronary artery venous fistula.
Coronary artery venous fistula.
Draining into the right artery. So these are the few conditions where you can get a prominent V wave in the neck. Okay, right. Very good, excellent. Yes. Okay, so here there is no JVP is not elevated, nothing. So if the patient is so, what is your comment about the septostomy procedure which we think the patient has undergone?
It is good, sir.
It's good. They have done a good job because JVP is not elevated, AVs are not prominent. So obviously meaning that there has been an effective opening of the intra-atrial septum. Okay, very good. Yes. Say it's very important to think at every stage so that you can think of many conditions and then finally come to the correct diagnosis.
Yes, sir.
Okay, we'll go to the next slide. Okay, yes.
On inspection and palpation, the shape of the precordium was pectus carinatum, and apex beat was visible and palpable.
What is this pectus carinatum?
Depressed chest.
Depressed sternal depression.
No, sir, it will be prominent, sir. Prominent.
Carinatum is the pigeon-like chest.
Yeah, pigeon-like chest. When there is a depression of the chest, what do you call it?
Excavatum.
Excavatum. Okay, right. Yes. Usually, patients with a recurrent respiratory tract infection can have pectus carinatum. Okay, right. Yes. Go ahead.
Apex beat visible and palpable in the 6th left intercostal space, 4 centimeter lateral to the midclavicular line. Diffuse, forceful, RV type. With no thrill.
Say that's a cardiomegaly, and whenever you are getting a patient with cardiomegaly, and if you think the apex is LV type, What when a patient is cyanosed, what are the conditions?
Sir, endocardial cushion defect.
No. First one, that is not the first one you should mention. Patient is having cyanosis, LV type of apex.
The tricuspid atresia.
Tricuspid.
Very good. Tricuspid.
Tricuspid.
What else? LV type of apex. Because in most of the times when there is a endocardial cushion defect, actually the RE will be more dominant because usually the shunt is from left to right. Sometimes you can get, but if you want to make qualified, you should say that the patient with a total allowance, total AV canal defect with a prominent MR. If the MR is significant, then that can give rise to LV apex. So it can be included. Yes. What else?
Top.
No, top. You have to, usual top will not give rise to LV apex. What? In what condition can the top will have LV apex?
Cooptation or TGA, sir.
Not common. What are the situations in which in a patient with top in tetralogy fellow you can get LV apex?
Aortic regurgitation.
Aortic regurgitation in an adult. Wherever when an adult tetralogy fellow, sometimes the patients can have significant aortic regurgitation. About 10% of patients with adult top can have aortic regurgitation. Sometimes it can be significant and can give rise to LV type of apex. 1, 2.
Sir, very large collaterals if present.
Very good. If there are large aortopulmonary collaterals or man-made shunt, especially a central man-made shunt, the port shunt or Watson Cooley shunt, these are not being done nowadays. But if a patient had such a procedure many years ago, and if there is an increased pulmonary blood flow over a period of time, the LV can increase in size and there can be a LV apex. So these are the two situations. One, the collateral flow either from a natural collateral, aortopulmonary collateral, or man-made collateral, or in a patient with adult tetralogy fellow, if there is a significant aortic regurgitation, sometimes you can get LV apex in a tetralogy fellow. Okay, right. Yes. What are the other conditions where there can be LV apex and cyanosis?
Single ventricle physiology. Single ventricle.
Single ventricle, very good. Single ventricle, 80 to 90% of single ventricle is LV type, and they can have LV apex. Very good, excellent. Yes. What else? Say it. Any thought process? Okay, it could be in a patient with double out the right ventricle with. Can anybody complete? In a patient with double out the right ventricle with restrictive VSD. If there is a restrictive VSD in a double out the right ventricle, it behaves like pulmonary aortic stenosis because the VSD is the outlet for the left ventricle, and if it is restrictive, that may sometimes behave like aortic stenosis because it is restrictive ventricle. The LV is, or the outlet for LV is the small VSD, and these patients sometimes can have an LV apex, and they may be they are cyanosed also. Okay, right. Yes. So these are the few conditions you should suspect when there is cyanosis associated with LV. Say it. Can you repeat?
First is tricuspid atresia, sir.
Very good.
Then a single ventricle.
Good.
Then that.
Went off with different situations.
Okay.
Aortic regurgitation.
Increased collaterals or a man-made shunt. Very good. Yes.
Top with AR.
Top with AR. Yes. Okay.
So the endocardial cushion defect with predominant MR.
Yeah, endocardial cushion defect with significant MR. Very good. And also
DRV.
DRV with restrictive
VSD.
Okay. So these are the conditions in which you can get LV apex and cyanosis. Here, of course, RV apex, RV type is the commonly associated with the cyanotic congenital heart disease. So there is nothing special there. But when there's LV, there are only few conditions. Okay, right. Go ahead.
On there was no sounds were palpable.
That's very
Parasternal heave.
We are suspecting what? So we are suspecting increased pulmonary blood flow, and so at this stage, what are we suspecting? If a patient has got increased pulmonary blood flow, what might have happened?
The palpable P2.
Yes, palpable P2. Okay, the patient might have had pulmonary artery hypertension, Eisenmenger syndrome, and palpable P2. Why then? Why P2 is not palpable?
Sir, because maybe transposition, sir.
Yeah, because maybe transposition. Explanation.
Sir, anteroposterior disposition, sir. They are.
Yeah, yes. The pulmonary artery must be posterior, and hence you are not able to palpate the second heart sound in spite of pulmonary arterial hypertension. Okay, right. Yes, go ahead. Yes.
Parasternal heave is present.
Every stage you should say it. See, yes, whenever we get a physical pain, you should start thinking, why this child, why this patient where we are suspecting pH, why S2 is not palpable?
Yes, sir.
Why the second, the pulmonary, you should always think of the possibility. Okay. Yes, why are it is but S2 is palpable here?
S2 is
aortic component.
Aortic come forward, so it's.
Yes. So in a patient, sometimes the S2 can be palpable because of the aortic component can be palpable. Okay, very good. Yes, it is more superficial. Yes. Okay.
S2 is palpable in second left intercostal space. No suprasternal pulsation. Epigastric pulsations are felt. RV pulsations.
Okay. Epigastric pulsations are felt. There are RV pulsations. Okay. Very good. Yes.
On percussion, there are no abnormalities detected. On auscultation, S1 was heard normal, S2 was single, loud in the pulmonary area, no S3 or S4. There is a constant ejection click audible in the pulmonary area.
Okay, so explanations. Why the second sound is single?
Sir, again the same explanation, sir. Pulmonary artery is behind.
Okay, very good. So pulmonary artery is behind, so the pulmonary sound may not be reaching the
superficial over
over the anterior chest wall, and hence the sound of what you are hearing single is actually the aortic component. Okay, right? Yes. Two, but the second sound is single and loud. So what may be the reason?
So aortic component, because its position of the aorta comes forward, so it appears to be loud.
Okay, it can be loud, but it is single. So okay, yes. What are the? I'll go ask you another question. What are the situations where you can get single second sound?
So because of pulmonary hypertension.
Yes, but VSD PS is the not VSD PS. VSD Eisenmegerization is the most important reason for single second sound, because where the pressure in the aorta, pressure in the pulmonary artery, pressure in the right ventricle, left ventricle, systolic pressures are all same. So that will give rise to A2 and P2 occurring together, and that will give rise to a loud second heart sound. Yes, 1, 2. So it's single sound. Single sound because both are occurring together. 2. Yes. You would give the mechanism and give the explanation, give the example. So the mechanism is here. Both pulmonary component as well as aortic component occurring together. Example, Eisenmenger VSD. 2.
Truncus will have single. PGA will have single.
Single valve. Example, truncus. Another example.
Atresia can have single.
Atresia walls, sir, pulmonary or aortic atretic wall.
Yes, pulmonary or aortic atresia. That can have single valve. That can give a single sound. Very good. Single valve. Okay, so tricuspid atresia. Sorry, truncus arteriosus, pulmonary atresia, aortic atresia. Very good. Yes. Third mechanism.
Severely stenosed semilunar valves.
Yes, one of the valves
like severe PS or AS.
valve and it is delayed and is very feeble and is not audible, especially very slightly posterior. So a feeble P2 which is slightly posterior and is not audible, as can occur in nephrology of fellow, where there is a very feeble P2. Okay, it's almost inaudible. Okay, right? Yes. Fourth mechanism. May not be cyanotic conjunctivitis in general. I am asking what is the mechanism for single second sound.
So when both are coming together, like sir, aortic sound is delayed or the pulmonary sound is coming early.
No, that we have already mentioned occurring together, which can occur in, for example, Eisenmenger syndrome. You can get A2 and P2 occurring together. Or there are some conditions where it can occur together. For example, in patients with sometimes in aortic regurgitation, it can occur together. There are a few conditions where it can occur together. So that the mechanism you have mentioned. Any other mechanism by which you are
pH loud P2 can mask the A1, A2.
Beg your pardon?
Severe pH loud P2 sometimes can mask the A2.
That's very unlikely. A2 getting masked is very unlikely because A2 is a dominant sound. Otherwise, pulmonary artery is posterior and sometimes the sound may not be audible. Example?
TGA.
TGA, very good. TGA, where the sound, the pulmonary artery is posterior and the sound is not, pulmonary component is not audible. Okay, any other mechanism?
Single similar was the trunkus arteriosus.
And that we have already mentioned. Single valve, trunkus arteriosus, pulmonary atresia, aortic atresia. Sometimes there may be a loud murmur which may mask one of the sounds, as can occur in a patient with aortic stenosis. Sometimes the pulmonary component may be masked by the murmur. Similarly, in a patient with pulmonary stenosis, aortic component also may be masked by the loud murmur. Another mechanism is the valve may be, the deceased valve may be calcified and is not creating any sound, as can occur in some other patients with densely calcified aortic valve. Sometimes you may not be able to hear the aortic component of the second heart sound. That can also happen. So you must, whenever there is you are hearing a single second sound, you should give an explanation. Here, the second sound is single. What are your explanations? Maybe the patient may be having Eisenmenger physiology, may be having a large VSD. So the second sound is both occurring together and is single. That may be the best explanation that you can give, looking at the story of the patient as well as the progression of disease process. Okay, right, go ahead.
There is a mid-systolic ejection murmur in the pulmonary area.
No, you have to give explanation for that constant ejection click.
Yes, sir.
Where is it coming from? Is it from the aorta or is it from the pulmonary artery?
It's from aorta.
Okay, you are thinking it is coming from the aorta. Okay, why did you say it's coming from the aorta?
Because with transposition of great arteries, single sound, more audible, and followed by ejection system.
In transposition great arteries, is there a pulmonary aortic ejection click? What is the mechanism? You can get aortic ejection click in nephrology of fellow, but not in transposition great arteries. No. Here the sound is audible in the pulmonary area, and you should always start suspecting whether it can be due to not pulmonary stenosis, because constant ejection click can be due to pulmonary artery hypertension, dilated pulmonary artery, and that can be it's a vascular click, and it can be still pulmonary artery. Aortic click is not common in a patient with transpositional great arteries. So don't think about aortic click in transpositional great arteries. Okay, right? Yes. Now coming to the murmurs.
So, there was a mid-systolic ejection murmur in the pulmonary area, rough, medium pitched, with no conduction, grade 2/6.
Okay, what may be the reason?
Due to pulmonary hypertension.
Okay, how can the pulmonary hypertension give rise to a murmur? Mechanism?
because of the development of the pulmonary hypertension, the flow the flow will not increase, but sir, the gradient, not gradient, sir. For the same regions, like sir, we are getting the vascular click.
So for that, you should know what are the mechanisms of mid-systolic ejection murmur. There are 6 mechanisms, 7 mechanisms. Can anyone of you tell me what are the mechanisms of mid-systolic ejection murmur, which is the commonest murmur that you are going to hear, so that when you hear that murmur, you should be able to give an explanation. Mechanisms of mid-systolic ejection murmur. Ejection murmurs are mid-systolic always, so there is no need to tell mid-systolic ejection murmur. If you mention ejection murmur, that's enough. What are the mechanisms of production of ejection murmur?
One is due to increased flow.
Increased flow across a normal valve. Okay, very good. Yes. Example?
AR severe.
Aortic regurgitation or pulmonary aortic regurgitation.
Aortic regurgitation. Another is?
ASD, sir.
Atrial septal defect.
ASD, very good. Okay, right.
ASD.
Second mechanism?
Diseased valve.
Diseased valve. Stenosed valve, normal flow. Example?
Aortic stenosis, pulmonary stenosis.
Very good. Third mechanism?
Dilatation of the vessel and dilatation of the pulmonary wall. Dilatation of vessel and into turbulence.
Yes, dilatation of the blood is being ejected into a dilated vessel, and that will give rise to turbulence. Example, aortic aneurysm, the pulmonary artery hypertension with the dilated pulmonary artery can give rise to turbulence, and that can result in ejection systolic murmur. Okay, fourth mechanism.
Structurally abnormal wall, sir.
Structurally abnormal. Example,
bicuspid aortic.
Bicuspid aortic. Sixth mechanism. Another mechanism.
So like increased flow, like sir, on normal valve, like sir, anemia.
Hyperdynamic circulation.
Hyperdynamic circulation.
Hyperdynamic circulation, the flow as a whole may not be an increase, but there is an increase in the flow in the early part of the systole that can give rise to ejection systolic murmur, as can occur thyrotoxicosis, anemia, beriberi. And one more reason is that valve is normal, not stenosed, but sclerosed valve, as can occur in aortic sclerosis. So here, what is the mechanism of this mid-systolic ejection murmur? Most likely because of the dilated vessel, and the blood is being...
And turbulence.
And turbulence. Okay, right. Yes. Second murmur.
Second murmur was early diastolic, blowing, high-pitched, short murmur, best audible in second and third left intercostal space, close to sternum, no change with breathing, and better audible in the sitting up and leaning forward position, grade 2/6.
Okay. What are the cause of an early diastolic blowing murmur?
AR.
What else?
PR.
PR, yes, PR.
Pulmonary regurgitation.
Pulmonary regurgitation, yes. What else?
Proximal LAD occlusion.
Okay, proximal LAD stenosis. People have described a murmur. I never heard it, but examiners may ask you that question. What is the name of that murmur?
Dogs.
Dogs murmur. Okay, yes. Another is one more early diastolic murmur you should mention.
Austin Flint.
No. Austin Flint is not early diastolic.
Sorry.
Truncus arteriosus. There are three main regurgitation murmurs. They are one, aortic regurgitation, pulmonary regurgitation, truncal regurgitation. And then you can add Dock's murmur also as a reason for early diastolic murmur. Okay, right. Yes, go ahead. So of these, which one do you think that this patient is having?
AR.
Why do you think it's AR?
The PR more likely.
Why do you say that PR is more likely?
Because of the development of pulmonary arterial hypertension.
1, 2. The location of the murmur.
And location also, sir.
It is in the second and third left intercostal close to sternum. There is no mention of the murmur in the right intercostal. So by location wise, it's more likely to be, and we are suspecting pulmonary arterial hypertension, and these patients can develop pulmonary regurgitation. I also would agree that it's more likely to be pulmonary regurgitation. You can, but always you can discuss aortic regurgitation, because by far early diastolic murmur, the commonest is aortic regurgitation. So always, and also there are no peripheral signs, nothing to suspect aortic regurgitation. All put together, I also would favor that this could be pulmonary regurgitation. Okay, right? Yes. No other murmurs. Okay.
No other murmurs. In the respiratory system, trachea was deviated to right, and pectus carinatum present. No adventitious sound heard over the lung fields. Liver was palpable 2 centimeter below the right costal margin. Gastric tympanic note on the left side. Spleen was not felt, and there was no ascites. So last line I'm not able to see, sir.
I'll read for you then. There is a upper neuron type of paresis of the upper neuron type paresis or left upper limb. That upper neuron type of paresis of the left upper limb. This may be due to what?
Cerebral abscess which has developed.
Yes, you had an abscess in childhood that might have resulted in a upper neuron lesion, and that is he is having still paresis secondary to that. Okay, right? Yes. So now you discuss the case, your diagnosis, provisional diagnosis. Come to the diagnosis, you tell the physical findings, and then you tell what is your possible diagnosis. You need not be always right. In cyanotic congenital heart disease, you may have difficulty in coming to the clear diagnosis. It does not matter. But you should be able to discuss with the examiner and support your thought process by physical findings. That's all. The examiner also can be wrong. Everybody can be wrong when you do an echo. But that will never that alone will never examiner will never fail a candidate. But whenever you give a explanation or when you give a deduction, you should be able to give a explanation. That is all. So originally we thought that this is a high flow situation. We thought that the patient may be having transposed congenital arteries based on the septostomy that the patient had undergone. So do you think that you would like to continue with the same diagnosis, or you would like to move to PS VSD situation?
The high flow situation.
You want to high flow. You have to tell me the reason.
Because sir, balloon the septostomy was performed.
No. Those things are over. So story is over. Now your physical findings are here, and based on that you have to draw conclusions, and then you can put both together and draw the final provisional diagnosis. Is the patient having cardiac enlargement?
Yes, sir.
Yeah, patient is having cardiac enlargement. Cardiac enlargement usually means there is a
Sir, high flow situation.
High flow situation. It is in high flow that you get a cardiac enlargement. So this patient is having apex between 6th left intercostal space, 4 centimeters lateral to midclavicular line, significant cardiac enlargement. So this is a most likely it is a high flow situation.
And the pectus carinatum also suggests same.
The pectus carinatum also suggests childhood recurrent respiratory tract infection, increased pulmonary blood flow. All those points are in favor of a increased pulmonary blood flow. Okay, right. Yes. Next question that you had asked is that do you think that the original thinking that is transposed congenital arteries, do you think that there are features to suspect transposed congenital arteries? It's very difficult to be certain that the patient is having transposed congenital arteries, but there is evidence that the
second sound
is a point in favor of maybe aorta is anterior, and also you can also suspect that patient is having significant pulmonary artery hypertension as evidenced by the loud, the single sound which is loud in the pulmonary area, pulmonary regurgitation. We are suspecting pulmonary regurgitation. That also is more in favor of
RB is a pulsation in the epigastric.
RB pulsations in the epigastrium. All are points for us to suspect that patient may be having. RB is very RB is at stress. So in a patient with transposition, RB is at stress because the RB gives rise to what? What does it?
Systemic this one, aorta is attached.
So here you cannot draw definite conclusions, but there are many points for us to suspect that patient is having an increased pulmonary blood flow, and also it is quite possible that the pathology may be the
Transposition.
Transposition. Can it be single ventricle? Sorry, can it be single ventricle? Which is an admixture lesion, single ventricle, not based on the history because patient has undergone a septostomy. That is against the diagnosis of single ventricle. From the physical findings,
It is RV type apex, so single ventricle is
the point against you expect the LV type of apex in almost 80 to 90% of patients with single ventricle. Okay, right? Yes. Any other point? So what is your final provisional diagnosis based on the clinical findings? Say it.
So it's a cyanotic congenital heart disease.
Very good.
With in failure.
No. Whenever you are diagnosing, one is cyanotic congenital heart disease. Next, what you should mention?
Situs solitis.
Situs solitis, very good. Next.
Then sir, levocardia.
Levocardia, yes. These things should be mentioned. And now especially pediatric cardiologists are very particular that these things should be mentioned. Cyanotic congenital heart disease. That's the first point. 2, the situs solitis. 3, levocardia. Then you can describe the morbid anatomy. Yes. We are suspecting
Transposition of great arteries.
Yes.
With patient in features of congestive heart failure.
What is evidence?
So patient had enlarged heart with features of bilateral edema.
Okay, so there's some bilateral edema and
hepatomegaly.
Hepatomegaly.
Treated heart failure. Okay,
yes.
We'll make it. Patient is treated heart failure because features of gross heart failure is not there. But I agree with you that cardiac enlargement is not a feature of heart failure, but there is bilateral edema, but JEP is not elevated. Maybe partly treated heart failure. Okay, right? Yes.
With pulmonary hypertension.
Pulmonary hypertension, very good. We are suspecting transposition of great arteries, so we will continue to hold on to that. Transposition of great arteries.
With history of
brain abscess.
cerebral abscess.
Brain abscess. Pulmonary regurgitation, you should mention pulmonary regurgitation. Pulmonary artery hypertension, pulmonary regurgitation.
Okay.
Failure. And also history of septostomy. And also history of brain abscess. Okay. Brain abscess. Okay. Right. Okay. Now we will go to the ECG and X-ray also. And what would you like to see first? ECG or X-ray?
Sir, ECG.
ECG. Okay. Why do you want to see the ECG? Why do you want to see the ECG?
So from ECG, sir, we can know the looping and axis.
Yes,
and
sir, very important. See, abnormal axis is more often associated with problems like developmental right ventricle or transposition of great arteries. So you can look at the looping. You can also look at the abnormal axis, And also you can look at
And also, sir, some bradycardia or heart block or anything.
yes. And also we can look at which ventricle is dominant, whether it is a right ventricle is dominant, left ventricle is dominant. All those things can be made up. We can be made out from by looking at the electrocardiogram. So we look at the electrocardiogram. Can you see it? I don't know whether.
Yes, sir.
Yes, sir.
Okay, so what do you give your comments about the electrocardiogram of this patient?
So it's with the paper speed at 25 millimeters per second.
Okay.
And with normal standardization.
Okay.
Showing a normal sinus rhythm with prominent P wave. And, it's a RVH with pattern, incomplete RBB.
What is the axis?
Axis is sir.
Extreme right axis.
Extreme right axis.
Is it?
Is it? The northwest type of axis.
No, it's a right upper quadrant axis. Actually, the axis in the right upper quadrant, you have to find out looping, whether it is going through the left side or right side.
Loop, sir, counterclockwise. Sir, because sir, 1 and AVL we can see the Q wave now.
In 1 and AVL there is a small Q wave, so initially it is going towards the
counterclockwise. Sir.
Okay.
You can't be. Why did you say counterclockwise? After the initial Q wave, it is becoming positive. Let me
if
see.
1 and AVL Q wave are present, then counterclockwise.
Counterclockwise.
Yeah, 1 and AVL there is a Q wave, that obviously means that either the loop is going away from the left upper limb. So it's moving towards right first, then it is coming towards the left upper limb, and then it going towards the right upper quadrant. Okay, it can be counterclockwise. I agree with you. It's counterclockwise loop. Yes. Counterclockwise loop. What else? Axis in the right upper quadrant. Okay. Then what about the
very prominent R wave with the Q waves in V1.
Very prominent.
R dash is there, sir.
Yes.
Very small R is.
Yes. R dash pattern in V1 indicating right ventricular hypertrophy.
And sir, V1 sir, P waves also, sir. Most probably, sir, they are RA dominant. Those are negative wave in the V1, but sir, they are sharply going down. So, sir,
I agree with you that going down is sharp, but you can't be 100% certain.
So that Mori's index.
Yeah, but because see, whenever there is an RA dominant wave, I would have expected slightly more prominent initial R wave, initial upright wave.
Sir, but in lead 2, sir, it is like a very prominent P wave.
Yeah, yes, I agree with you that I would compromise saying that both right atrial enlargement and left atrial enlargement both are there. But if in V1, if the initial part of the P was showing an upright reflection of more than or equal to 1.5, then I would have fully agreed with you.
Yes.
But here the initial reflection is practically very little. Okay, so from the ECG we will diagnose the patient is having right atrial enlargement, left atrial enlargement. There is a counterclockwise loop and axis in the right upper quadrant. Okay, right, yes. What else? Right ventricular hypertrophy. Early transition. Is there an early transition from V1 to V2? What is the condition in which you get early transition?
Pathology. Pathology we get early.
Yes, pathology. Usually it is associated with large VSD. Whenever there is a large subaortic VSD, you can get a early transition. The classical condition is pathology of fellow. Is there an LVH?
So there is possible because S wave is persisting in V6.
Beg your pardon?
S wave is persisting in V6.
persistence of SVM in V6 does not
Sir,
mean that there is LVH.
Sir, if we go more laterally, then sir, we may get prominent R.
Okay, then because the patient has got cardiac enlargement and 600 space, it's better to repeat the electrocardiogram one space down and more up to V7, so that if there is any LV forces which has not been picked up, then that can also be picked up. Okay, right. Yes, so we have to do a electrocardiogram with the one space down and to the up to V7. Okay, right. Yes. From the base of this electrocardiogram, what do you think would be the diagnosis? Electrocardiogram supports what? Roger fellow, transpositional great arteries, single ventricle. What is the possible diagnosis which is based on the electrocardiogram?
Transposition.
Transposition.
It's transposition because of the counter clockwise loop, the northwest or the right upper quadrant axis, the right ventricular hypertrophy. All these points are in favor of
Transposition.
Okay, I think it's 9 o'clock. We should stop at this level. We will continue with the X-ray and echocardiogram in the next class because I don't think otherwise it will take another half an hour to 45 minutes. So far, any doubts that you have, you can ask now, and we will continue with the discussion of the X-ray and echocardiogram in the next class.
At what pulse, sir? At what pulse oximetry value we should label cyanosis? While we perform pulse oximetry, what pulse oximetry level we should label patient as is having cyanosis?
That's what I said. If the patient is having polycythemia at around 85%, you will definitely the patient will be cyanosed.
Sir, we should only with pulse ox, if we are examining the patient, that time if we see that the patient is having cyanosis of patient is having pulse SpO2 of 92, 93, we should label that for as cyanotic heart disease. 92% or 90%.
93, you will not have cyanosis.
So yes, she is not having cyanosis. Sometimes patient actually, sir, we encountered like that patient is not having cyanosis, but saturation is low in all limbs, sir. In that case,
in that patient may be having anemia.
Okay, sir. So in that
because
case,
see, mostly patients with polycythemia are the ones which develop cyanosis.
Yes.
If the patient is having only 10 grams hemoglobin, even at 80%, patient will not be cyanosed. Okay. Even it has to fall to around 75 or 70, then only you can detect cyanosis, because cyanosis is a function of how much oxygen reduced hemoglobin. Yes. So for reduced hemoglobin, there should be adequate hemoglobin. So if the hemoglobin is only 5 grams or 7 grams, the patient will not be cyanosed at all. So whenever you find that the patient is having an oxygen saturation of 80% and or 79% and the patient is not cyanosed, if the examiner asks you, you should say that most likely patient may be having anemia.
In final diagnosis, how we will mention that congenital cyanotic, like with history, the patient is not having cyanosis.
So you are discussing an imaginary situation.
Actually,
because most of the times, if the patient is having cyanosis, cyanotic congenital heart disease, their hemoglobin will be more than 15 grams.
Yes,
but if the patient is having a hemoglobin of 8 or 10 grams, then even when the oxygen saturation is 70 or 80, the patient may not be cyanosed. That is mostly occurs when the patient is having pulmonary edema, all those situations where the patient's oxygen saturation can be low, but if the patient is having anemia, then they may not have cyanosis. But cyanotic congenital heart disease is a very, very different situation.
Okay. Thank you.
Okay. So I think, Said, you can continue with the discussion in the next class.
Yes,
You will have the X-ray as well as the echocardiogram in the next class and continue with the discussion.
Yes, sir.
Okay, right. Any other doubts? Okay, right. Thank you. I think.
Thank you, sir.
Thank you, sir.
Okay. Thank you, Aarti. Thank you.
Thank you, sir. So can I end the meeting with your permission?
Yeah, okay. Thank you. Thank you.
Okay, so I'm ending this meeting now. Thank you.
Thank you.